Thank you. Thank you, Kumar, for this invitation to shamelessly show my complications. This is one opportunity where I would definitely not like you to judge my surgical skills by the videos you see, because the purpose of this particular course, I think, is to shamelessly show our complications. And you've heard of a stitch in time that saves 9. I'll show you a nick in time creates 9. I think this, yeah. This was selected for the ACRS challenging cases, I think a year before last. A heroic surgery, you'll see how I'm forced to do a heroic surgery and make a mess of the situation. Where is the start? Yeah, it's moving now. Okay, so this was a supra-hard cataract. Patient had come from outstation for this surgery, had a lot of faith in me, and they could see the cataract, and I'm injecting trypan blue under air. Watch very carefully. Watch very carefully. There. I didn't see it. I'm so confident using trypan blue under air. Watch it in slow motion. In fact, I thought that was a non-staining area. So I injected some air to see what was happening over there. And only when I had that air in place, I realized, oh, this is not a non-staining area. There's a flap over there, which I nicked the capsule with my trypan blue cannula. So what I had to do now is I couldn't just dump the case and walk away. So I went ahead and created a capsulorhexis on either side. So I have a split capsule over there. The anterior rim is split till almost the equator over there, and this is a rock-hard cataract, and this is going to be a nightmare, I know. So I have put in Helon, stabilized that nucleus over there. Watch that phaco probe and the wound over there. I am not looking at that at all. I've got Helon packed in my chamber, and I'm going for a direct chop. I want to minimize the rocking of the nucleus. I'm really not looking, and I forgot that there was Helon in the anterior chamber. That's what tension can do, anxiety can do. Not that I'm a very experienced surgeon, but then I have spent a few years doing phaco, and this is what I'm doing. Watch that cornea. It's slowly turning pale white, and wait, that's not the end of the story. Wait till it gets chalky white. If you have not seen a bad wound burn, this is a good opportunity to see what you should not do. I would pray that none of you ever have to see a wound burn like this, because I regret this particular case all my life as to why I was not looking at the incision. I was so conscious this is a hard leathery cataract. I had to break that posterior plate. I knew with every movement that I would probably have a wraparound tear which would go around the equator and go to the posterior capsule. I did manage to salvage this situation by doing that cataract all right. I dealt with the nucleus all right probably, but I had caused a huge burn, and I knew the moment after I realized very soon that I had caused this burn, and so I knew that the moment I take out the probe, you see what happens. Now, so far it's all right. Now I'm injecting viscoelastic because I know that my anterior chamber is going to collapse the moment I take out my probe, because that wound is going to just fish mouth like that. It just pouts, and everything that you put into the anterior chamber comes out. Anyway, this is at the end. While I'm doing the IOL, I just had to extend it a little bit to put in the IOL safely. So I'm using a multi-piece IOL over here, and this went off well. I put the IOL in the sulcus, and I had a very well-centered lens. There was nothing wrong with which went off because of the rhexis tear, but I had a terrible wound burn. I had done a heroic surgery. And don't ask me what the patient's post-operative astigmatism was. I am really ashamed. Whenever I see my notes, I tried everything. I cut those sutures. I did everything. I had a very dissatisfied patient. So it's a small step, like just taking out the trypan blue cannula, and has led me with such a bad taste in my mouth for a very long time. See that? And so if you have a wound gape like that, you really have nothing else to do but put a couple of sutures. In fact, one suture is not going to really do the work over here, so you need two actually. I tried one, but this I think I had decided way in advance that one would not do, so I had to put two sutures over here. And you see, I have a fairly clear cornea. This cornea was clear, so I had managed the nucleus very well, despite the adversities, but this particular cornea was a mess over there, and I had a bad astigmatism. We'll go on to the next case. I've got two short 5 minutes cases. So this is a single piece IOL. I don't know what came over me the day. So I have a perfectly nice day. I didn't fight with my wife in the morning. So I was perfectly all right. So I was doing surgery, and we had a fair, I mean, this was not even a hard cataract. This was not even a moderate cataract. So quite a patient who was well known to me. So been my patient for a very long time. So went ahead with, this was not a very hard cataract, so I was not going in for the regular chop, so I was going for a stop and chop, and there we are. We have dealt with the nucleus. Happy story so far. The cortical cleanup also is uneventful. That looks nice, and I'm showing you all this because to show that nothing really went wrong throughout the surgery. And you see how I literally messed up a very clean situation. A Technis 1 IOL, I've been using it for as long as the Technis 1 IOL has been there in this country, probably one of the first users of the Technis 1 lens. Just see what I'm doing as I inject the lens. Now that was fine. I didn't know what came upon me, what was I doing. I just kept pushing and pushing that injector all the way. By no stretch of imagination could that bag be so huge. I think I was trying to put the trailing haptic back into the bag in one go. I don't know really what came upon me, and for me to think that that bag was still intact is all the more stupid. And actually, and I'm getting away all this time. I'm doing IA, and I'm really trying to see if that lens really moves or wobbles, and then I'll pull it. I need an excuse to now pull it out. Nothing is really happening. That lens is absolutely rock steady. It's not going anywhere. Till you see that. Can you just, I'll just pause over there, probably. Yeah. Do you notice that blob which has gone behind the lens? That's viscoelastic. When I saw that, I knew I have a compromised posterior capsule, and I have a lens in the bag, a single piece lens in the bag. There is no way on earth I could leave this lens behind, because this patient is going to come back to me, and unfortunately I happen to be a trained VR surgeon, so I can't refer this patient to somebody else also. I'll have to deal with it myself. So I went ahead. Now some of you might think that the immediate easiest solution is to probably do a reverse capture of the optic, where you bring the optic anteriorly and capture it in the rexus, because the haptics are already inside the bag. But remember, this is a Technis 1 lens. It's a biplanar lens. The haptics are at an anterior plane compared to the optic. So you just can't do that. In fact, I tried that initially, and I'm not showing that part because I didn't want to show you how foolish I was that day. And so I had to anteriorize the entire lens and bring the haptics into the anterior chamber. There I am. I really didn't want to mess up my capsule rexus, but these lenses are very good. The rexus also is very forgiving. So once I had that haptic, that was one haptic out into the anterior chamber, then we get the other haptic out. This is a very good device. It's a reverse Sinski. I think they use it for decimal scoring. So there I had both the haptics now in the anterior chamber. Now this is the only way you can tuck those haptics into the sulcus, the only way. Now this is a bit controversial, but there is a lot of literature coming up now, and trust me, if you have, now I'm not going to leave it in the sulcus like that. I am stupid, but really probably not that stupid. So the haptics go into the sulcus. Now all the issues of leaving a lens in the sulcus are because the lens moves against the iris. If I could do an optic capture in the capsular rexus, that lens would not move and there would be no chafing. So I went ahead and did that optic capture, and the test is that or the proof lies in seeing that you have a fusiform capsular rexus, which actually suggests that you have done a good optic capture. It looks like a starry night over there, lots of small air bubbles, But I got away with that, and I'll show you the post-op picture, which shows that we have, this was a small stand of vitreous which was coming. I really didn't want to add to my woes by going in with the vitrector. So I said, okay, just one strand, let's chop it off and take it out, and the rest would retract. And I had a nice round pupil. I injected pilocarpine, so there were no strands over there. Post-operative day 7, I have a nice fusiform capsular rexus suggesting that the lens is absolutely well centered. And we did a UBM to be sure, and you see the lens. There is a lot of clearance from the iris. The iris is not deformed, suggesting that the haptics are not touching the back of the iris. And actually, pigment dispersion glaucoma is very rare in Indian population, and these situations can be forgiving, though there is not much of really published literature. I've done a few such lenses where a single piece IOL can be kept in the sulcus as long as it's fixated. So thank you very much, Kumar, for this opportunity.
Thank you, Suven.